You are listening to The Scope, Phelps Health Podcast, Episode 8. Let's get started. Hi everybody, I'm your host, Paige Heitman. The Scope Podcast is produced on a regular basis and can be found by visiting phelpshealth.org. Come back often and feel free to add the podcast to your SoundCloud stream, or you can follow us on our YouTube channel. Today our guest is Dr. Tim Martin, Division Chief for Phelps Health Medical Group Specialty Division and a cardiologist at Phelps Health. Dr. Martin, welcome to our show today. We're really excited to have you here. Before we get started, tell us a little bit about yourself, your education, your career at Phelps Health.
Okay. Well, been here about 20 years. Initially came in as an associate professor of medicine from Washington University, where we ran a clinic here. At approximately 7 years ago, they decided to close the clinic, and I decided to stay with the patients here. So my dad and I started the cardiology clinic here. And I've continued it since that point in time. And over the last several years, I've actually began moving into the administrative aspects of the facility and division chief of the specialty services here at Phelps Health.
That's fantastic. We're really lucky to have you. So 2 decades. What has kept you at Phelps Health?
You know, the area here is always something I've wanted to work in, the rural community, the family type of atmosphere that you get not only with the patients but with the people that I work with. They're not only people that I take care of, but in a personal note, you'll see them in the public and acquaintances and friends. There's no animosity.
Yeah, there's a personal touch that you don't get maybe in larger cities.
Great personal touch that you don't get. And and it's been a remarkable experience here.
That's fantastic. Well, I know we're all very lucky to have you. So what's really cool is that you recently went to New York to volunteer as a cardiologist at one of their hospitals. So I'd like to take a little bit of time before we dive into our topic and talk about your experience there.
Great. So yes, when the COVID hit back in early January, February, when we started to realize that this was going to be a pandemic, I started thinking about what that could affect our population here at Phelps Health. Now we're in the middle of Missouri, which is in the middle of the country, so I knew we had plenty of time before this would start to hit. At the time that the virus started hitting, we didn't know anything.
Okay.
Data coming out of China was very interrupted and very brief. As it started to hit the European societies and then now move into the United States, we started getting more and more of an indication that this was going to be a very, very detrimental virus and something that could be a problem for our health, for the health of the people down here. With that, we took measures to instigate the emergency operating centers and then shutting the system down and getting ahead based on what we were seeing in New York and New Jersey and the larger cities and how bad that was starting to hit them. So we started early here in Phelps County and shutting down the system. With that, obviously the number of patients, the procedures, all the elective cases that we were doing went down. And with the addition of our 2 new cardiologists, Dr. Phelps and Dr. Shockett, there were 3 of us pretty much doing very minimal work. At the time, with the advancement of the issues that were arising and the call for the need to help, I thought it was prudent that I take the opportunity to go learn about what was going on and get a better experience that nobody had at that point.
Yeah, nobody knew, especially in rural Missouri.
Well, Rolla, St. Louis, Chicago, New York, New Jersey. And two, it allowed me to do what exactly I've always wanted to do, and that is to help people. So I volunteered my services and put my name out there, and was contacted by NYU Medical School and Bellevue, and they asked me if I could come up and help. And so they flew me up there, put me in a hotel, and I worked up there for several weeks.
Wow, that's amazing. So what are some of your key takeaways from New York?
Well, the key takeaways from New York is that we're dealing with something that medicine has never seen before, and it was evident from day number 1 that the virus alters the physiology and the pathology of how things occur in the body, different than we've ever experienced. So we weren't dealing with just one organ system. We were dealing with a domino of organ systems in fashions and manners that we've never seen or experienced before.
So would people come in with all types of different symptoms? Is that kind of what you're alluding to?
The majority of patients would come in with shortness of breath, fevers up to 105. Rarely, but still very common, people would come in with nausea, vomiting, diarrhea. Very few came in with heart conditions, but that was still a presenting symptom for some. And still yet, even in rare individuals, but still very much more common, were in certain age groups, was that of stroke. People were coming in with new onset neurologic findings. Now I say it's rare, a more common but rare finding, because we were seeing it in young people that we wouldn't expect to have strokes.
Yeah, young
were
healthy
showing
people.
up with motor dysfunction, with speech impairments, with mental status changes, and finding that we had strokes on the CT scan, only to find out that they were also COVID positive. And when we did the workup, noted they had the characteristic findings.
Wow, that's very scary. So whenever we talk about New York, now that you're back here in Missouri and things are starting to open back up, what are you kind of recommending for patients and the community as we go out and social distancing efforts are still being recommended, but maybe not necessarily followed?
So the social distancing is going to be the key. Washing your hands. And it turns out that from the data that we continue to follow, is that it is the time of exposure to a COVID positive person and proximity. So there are individuals, rare individuals, who are COVID positive and carrying the virus and shedding the virus, who are asymptomatic, reportedly, not having any of the common findings. They may have felt fatigued or ill in some fashion and just pushed it off, but still shedding virus. You can't control that. But you can control your exposure rate to individuals, and that's with the masks and when you're out in public, and washing your hands consistently. I think someone once reported that we touch our face probably about 1,000 times a day without even thinking about it. Brushing our hair back, fixing our glasses we wear them. When you get an itch, when you feed yourself. We do this so inadvertently we don't think about that. And yet, if you have picked up the COVID virus by contacting on a contact surface that wasn't cleaned appropriately, and then you had to scratch your face, or you rub your nose, and you inhale the virus, you now are propagating it. So we can't control people in general, but we can control ourselves. And social distancing works, and wearing the masks.
Why is it so important for everybody to wear a mask, as awkward as it feels and as awkward as it looks?
The mask prevents the spread immediately of your exhaled breath. It diverts it laterally or down into your clothes. And when somebody coughs, you can actually get that out very quickly. Some up to 60 or 70 miles an hour, and it can go 3 to 4. It can go 3 to 4 times the distance of your normal breath, which can be 10, 12 feet. So the mask kind of reminds you that, hey, you need to be careful when coughing or talking in someone's direction. And it's best to still social distance with the mask on. And again, these are the people you can't control.
Yes.
The younger people, the people who feel like they're not at risk of having a problem are going to be doing what they're doing. So the best thing you do is social distance in there. When you see somebody down the hall, the aisle, move off to the side, face away from them. If they cough, you can ask them to cough into their shoulder, into their elbow, or into a Kleenex away from you.
Yeah.
So it's going to be important, I think. I don't think that we're going to see the numbers that we did in New York. We may get several cases where people get it and they go into the respiratory components, what we call the respiratory distress syndrome.
Okay.
I don't think we're going to see the numbers.
Why is that?
Mostly because New York, you put about 8 million people in 10 square miles. And I think that the bigger cities that are having the problem are the ones that have the mass transit. When you get on I've been in New York before the COVID, and you're getting stuffed into a mass transit system, and somebody's not feeling well, and they cough into their hands, they're not touching the railing, or they cough openly without thinking about it, and it's now throughout the entire car.
Yeah.
Now all those individuals are now infected, they take it home. And so I think it spread rather quickly.
Do you think it's already hit here in Rolla? or do you think that we're waiting for some type of hit to occur?
The data is unclear right now whether or not we have people that have had it and are asymptomatic because we've not had the tests. Those tests are now coming. And people can find out if they've been exposed, or if they've had it acutely or chronically, and we're getting better at that. We just recently purchased and started testing equipment for rapid testing here at Phelps. So we're hoping to improve our diagnostic accuracy. Do we have it here? We probably do have it in society somewhere, probably through travelers who've come through. Has it hit? Not really. We haven't seen anything, although we're very acute. We're very hyper acute to the individuals coming in with shortness of breath and fevers and nausea, vomiting, and sudden onset of diarrhea or headaches. We're testing them regardless and isolating them and pretending like they do have it until we get negative tests. But even in a negative test, people have to understand that the original test that we're using, sensitivity can be as low as 48% and as high as 70%. So we're missing quite a few. Just because you have a negative test doesn't mean you're negative. It just means we didn't pick it up.
Wow. So could somebody get retested then, or how does that work?
We retest.
Okay.
Right. And so a positive test, on the other hand, is you have it. So the positive predictive value is great. The negative predictive value is not. So we have to be smart about it.
So I have one more question, and then we'll transition into our next topic. As a rural community, which is what Rolla is, and we're classified as a rural hospital, and how can we benefit from your time in New York? What are some things that you've brought back, or some teachings that you've shared with other providers in the community?
So what I've learned in New York, and what I've already brought back, and I've had some meetings with the group of individuals for the CMO at the hospital CMO at the medical group, and with the hospitals who are the main caretakers, along with the anesthesiologists. We've already instigated, and that was before we even left anyway, on how we're going to treat and what we're going to do. With the knowledge of New York is then, as I've told everybody, just throw standard medicine out the window. Just throw it out, because what we're going to see if we ever get to that point is nothing like you've ever experienced. And what you think will work often is detrimental. So we've instigated a process that if individuals are COVID positive and having respiratory issues, that myself and Dr. Sabran, our pulmonologist, will ultimately assume a consulted and interactive care with these individuals along with the hospitalist, and start managing them in hopes to curtail the problems that we've seen up in New York.
Well, it sounds like we've been very lucky to be in a rural community. So for that, we should probably be very thankful.
Yes, we've been isolated, and we've got it on the periphery, and it's slowly going to move this way now. With the summer season coming and people getting tired of being isolated and homebound, they're starting to migrate in their campers, and so we may start seeing a spike here. And that goes along with the problem. People don't think that they have it, that I just have a little bit of headache, I'm a little dehydrated, and yet they do actually have the COVID.
Yeah, we have to be cautious.
It's a problem. They can be a fulminant viral load and fulminant viral pathology going on, and still look normal.
Yeah, and you just wouldn't know.
You don't know. The only clues would be that their lips might be cyanotic or slightly blue, their fingertips may be slightly blue, and they just don't feel well, they get a little lightheaded.
Yeah.
And they never really did get the fever, or they get a fever, it's just small, so they take some Tylenol and it goes away, and they feel a little bit better. And it's not until they fully inhibit their ability to oxygenate their blood do they really go crashing.
Yeah, they play this cat and mouse game with themselves.
Right.
Well, I think that's what's so scary about COVID-19 is there's so much that's unknown, and I think that's why the public has been so kind of on edge, because the people that we rely on, our public health experts, our providers, they don't know.
Right.
You guys are kind of playing it by ear.
Right, and that was the knowledge when I first got there. We've learned quite a bit since that point in time. We now know its effect on the multi-systems and how, and we think we now know how it's affecting the organ systems. The biggest one is that of the clotting system, which goes back to stroke.
So there's a lot at risk.
There's a lot, and what we see is, again, we see pathology and conditions that are just, that are overlapping.
Mm-hmm.
So we get a coagulopathy, we get cardiomyopathy, we get renal failure, we get liver failure, and and they overlap, but they're all related.
So whenever we correlate this to heart health, if stroke patients or previous stroke patients do get infected, are they at a greater risk of experiencing more or greater complications?
So we don't know the answer for that for sure, but the suspicion is yes. We do now know that the individuals that are most at risk are individuals who are overweight, high blood pressure, diabetes, or have a pre-existing immunological compromised condition.
So if somebody does get COVID-19 and they haven't had a stroke, but they have one of these other things like they're overweight or they're immunocompromised, are they more susceptible to having a stroke if they're overweight and they get COVID-19?
So we don't know the frequency again of strokes because these strokes are microvascular. Okay. The initial reports say that one of the things you can find out, you can look for people with COVID is if they had changes in sense of smell and taste.
Okay.
We now know that's probably related to microthrombi formation. It's a complex question and answer. We don't know. Are they at higher risk? Can we predict the risk? No. We do know that these individuals that get into this cytokine cascade, the cytokine storm, and develop these multiple different types of coagulopathies that are overlapping are at extreme risk of causing problems. We miss a lot of it because they're intubated and they're sedated and they're on high flow oxygen. And so in New York, we did our exams from outside the room. We didn't actually go in and examine them. We didn't wake them up. And so we didn't scan everybody because scanning everybody would have...
Well, you probably didn't have the time either.
Time and resources.
Yeah.
So we ended up treating them with just by the numbers of what was going on and trying the different type of medications.
Wow. So why is it so important right now for patients, especially in our area, to maintain their heart health during this time and even before COVID-19 hit?
Well, maintaining heart health has always been its key. The heart health, if you go into this infection with a detriment and you're already knocked down because of your heart and your deconditioned heart or your other issues, the chance of survival go way down. So the acronym they used when I got up there, when a person had more than 2 systems that had failed and they coded, they didn't proceed to try to resuscitate them.
Because of lack of resources?
99.99% failure rate.
Wow.
When they died, and they just die. They look like they're doing okay, and the next day they're passed away.
Was that really hard for you guys to deal with on a daily basis?
So it's hard to deal with it afterwards, not during. It's during the crisis. I think I can speak for a lot of physicians and nurses that work. They don't think about the ramifications and their own personal feelings. Their job is to focus on what can I do to save this person's life. And if you've been in the hospital, and the nurses and the physicians will know, when a code is called in the hospital and you have 10 or 12 people show up, imagine that every third room in an ICU floor that has 90 beds. 30 codes going on at one time, and the majority of them not surviving. When you get intubated in New York at Bellevue Hospital, where I was, and you were intubated, your death rate was approximately 88%. Mortality was 88%.
That kind of makes me think of the show MASH, if you've ever watched that, where they're doing this like meatball type surgery and they have all of these people out, all of these soldiers who are wounded, and they know that they can't save all of them, but they don't even have time to think about it.
In actuality, that's I use that very example when I talk to people. It's like, think of MASH in a big hospital. My first day there, I helped out on 3 tracheostomies. Where we took the tube that they've been ventilated and we put it into their neck and assisted on that for 3 of them. We were doing appendectomies, cholecystectomies, peritoneal dialysis catheters in the room. We didn't take them to the OR.
Because you didn't have time or the resources.
It was the infection. We didn't want to spread the infection throughout the hospital. We localized it, and the reality is moving it from one to the other was detrimental.
The risk of infection was too high.
Risk of infection, but the risk of the patient dying en route, because you take them off all the support, and you have to move them to another floor into the room, then bring it back, clean the room, and get them back and stable. So we just use the ICU rooms as operating rooms.
Wow. It's incredible that we can still do that and we can move that quickly, but it's unfortunate that we have a pandemic going on. Nobody ever, I think, wanted that to happen or really prepared for it. I don't think you can really prepare for a pandemic.
You cannot. I think we will be better off in the future. I think what we're going to find out is we're going to find out a lot about the immune system and its reaction to infections, and the immune system as a whole, and maintaining the normal physiology of day-to-day function. And we've learned quite a bit already about the immune system and autoimmune disorders and their effect on future disease process. Secondly, I think we're going to see a change in how people act in society. I think we're going to see the social distancing still occur to a various degree and during phases of flu and other issues. We're going to see a change in how people are addressing and be addressed, going out into the public or staying home. Lastly, I think, and more importantly, we're going to see what effects this has had on the healthcare system, not just financially, but emotionally and physiologically. With the physicians and nurses. When I was up in New York, I remember getting up at 5 o'clock in the morning, going to the hospital, and working till 7 at night, and then going home and collapsing. And you don't really get to deal with the trauma and the humanity to the significant degree you really need to. But it takes its toll. Even the ICU nurses here and the nurses on the floor will tell you, that when the code's going on and when things are really, crashing and you're doing what you have to do, you go home and all of a sudden you're alone. Now, I was so exhausted I didn't really hit. It hits afterwards.
Yeah, you don't really get a chance to process.
And you remember the 39-year-old that was doing well, had a normal echo the next day. His heart was just stopped in front of you, and everybody just walks to the next room because there's nothing you can do. It's going to be a daunting event to overcome. We'll get over the COVID. We're going to find we'll find a cure for it.
Yeah.
And it's going to come. And it came at the cost of a lot of people. One of the emergency room physicians that we were up there in New York actually, succumbed to that, to the psychological stresses, and it was unfortunate because we hate losing people. And she ended up taking her own life, and it just hits the system even worse because then you find out about that, and now you got to deal with the fact that the people that you're working with now
people who could be you.
Yeah, and so so I think we're gonna see a difference in the mental health and screening and health of the physicians and the nurses and the healthcare workers that are involved. Now, there was a lot of good that came out of that too. I mean, I don't want to leave people with it like, oh my God, this is so dismal. The reality is that when this all happened, the community came together like I've never seen. I walked out the first day, and lining the streets were the police and the fire people and people out of the streets, and they were just clapping, and the sirens are going off, and it was just amazing. Communities were sending food to the hospital, so when we came from our morning rounds, they would have food for us.
Yeah, and that really makes a difference. As we get ready to wrap up here, I want to give you an opportunity to speak to our community and to Phelps Health patients, employees, and to just give them any advice or insight into your experience.
So the advice is, maintain the course, take care of yourselves, wash your hands. If you're going to go out in public because you can't stay inside so long, try to social distance yourself and be aware of your surroundings. And if you're not feeling well, take care of yourself. Don't go out in public. Let's stay at home. People understand. From the healthcare workers, that we've gotten so much support from the community as it is, that just keep it up.
So that's some great advice to end on. It's certainly a great time to be informed as a patient and as an employee at Phelps Health. Thanks for listening to The Scope. I'm your host, Paige Heitman. If you liked our show and would like to know more, please visit phelpshealth.org. Thanks so much.